Thank you, everybody, for joining us this morning. Today, we have a special presentation on July's AIDS Clinical Conference. Today's presenter, he's a stranger to no one, Dr. Chase Cannon. You've seen him here at previous AIDS clinical conferences and also on other UW webinars and events, as well as Public Health Seattle King County. Dr. Cannon is a medical director at the Sexual Health Clinic at Public Health Seattle King County and also an assistant professor at the Department of Medicine here at UW. So Dr. Cannon, if you can please pull up your slides. Just a reminder, if you have any questions or comments, please type them in and we'll review them at the end of today's presentation. Dr. Cannon, please take it away.
Great, thank you, Victor. Good morning, everyone. Welcome to our July AIDS Clinical Conference. So today, I think I wanted to talk a bit about emerging issues in HIV PrEP and PEP. There is so much that could be discussed for both of these topics. Each of them could easily be an hour on their own, but I wanted to focus a little bit on some of the clinical conundra that we face and then talk a bit about what's coming for each of these two strategies. So in terms of disclosures, nothing personally, but I will be discussing some brand names and some approved strategies for PrEP, including for Descovy, Apretude, and Truvada, and you can see the names for each of those there. And we will be talking about some non-approved strategies for HIV prevention as well. And I do want to acknowledge that this talk came together with the assistance of the people that you see listed here, as well as the National HIV Curriculum. I'm going to base this a little bit on a format that I thought was interesting from a recent Mountain West AETC Faculty Development Conference. So this is our HRSA acknowledgement and our objectives for today. So again, to talk about some clinical uncertainty in PrEP care, reviewing considerations for viral load monitoring, which is a bit of a controversial topic right now, and then understanding some of the evidence for alternative PEP regimens. And this is our overview. There is a lot of material here, and we will anchor all of this in a case study that I think will be a good through line and may be relevant to those of you who are providers and who are caring for people who are using PrEP or who may need PEP. And again, we'll end with just some new strategies and sort of what's coming. So HIV diagnoses in the United States have been sort of stable to decreasing over the last several years. So in 2019, about 35,000 new diagnoses, and that's down about 8% from 2015. But we're still not at the target for our Ending the HIV Epidemic, or EHE initiative, which is a federal initiative aiming to reduce the number of new HIV infections by 75% by the year 2025. And then 90% by the year 2030. And so we've got quite a long way to go before we get there. And the way that the EHE initiative has proposed that we do that is with these 4 pillars, one of which is prevention. And that's going to be the focus of our talk today. So preventing new HIV transmissions using proven interventions, including PrEP, and then syringe service programs, which we won't discuss. For those who do not know, I'm not sure who's in the audience, but there may be people who are unfamiliar. PrEP stands for pre-exposure prophylaxis, and this is a prevention strategy where a person takes antiretroviral medications who is HIV negative to prevent acquiring HIV. And this is a strategy that we've now, had for over 10 years. And the United States Preventive Services Task Force has issued a grade A recommendation for providers and clinicians to offer PrEP to adults and adolescents who are considered sort of high risk for HIV. But in 2021, the CDC sort of went even further and updated their guidelines to now say that all people who desire PrEP should be offered PrEP. So that's was a bit of a game changer, because previously we had been sort of stuck in a lot of these risk assessments and asking people what their sexual history is, what their injection practices are. And that is important, but I think if anyone does come asking for PrEP, the key is that we should be offering it to them because they are often asking for a reason, even if they're not disclosing what those behaviors might be that would indicate them for PrEP. And then they also go on to say that all sexually active adults and adolescents should be informed about PrEP. And so that is sort of a goal of our session today, for all of us to be more informed so that we can tell any patients and clients that we interact with about PrEP. So there are currently 3 medications FDA approved for pre-exposure prophylaxis in the United States. So the first that you probably know is daily oral tenofovir DF emtricitabine. In this talk, I will abbreviate that as FTDF, and the brand name is Truvada, although it is now generic. It was initially approved in 2012. And then the second option is daily oral tenofovir alafenamide and emtricitabine, also known as FTAF or Descovy. So this was approved in 2019, but not for persons having receptive vaginal intercourse. And then injectable cabotegravir is the newest agent. Brand name is Apretude, to be given every 2 months. That was approved in 2021. And then lastly, the dapivirine vaginal ring, although that was accepted and approved in other places in the world, it was withdrawn from US FDA consideration in December 2021 because the agency that was putting it forth felt that it was unlikely to be approved, and so they removed that from the market in the US. Oral PrEP is highly effective, and we know that now from dozens of studies, many of which were led by faculty and researchers here at the University of Washington. So you can see a forest plot here on the left side that basically many of these studies are favoring PrEP. They have a risk ratio for HIV reduction that is significantly less than 1. But that really depends on adherence. And so on the right side, you can see a summary of the evidence that we have by population. So for men who have sex with men, or MSM, we know that PrEP is effective. And if we look at whether the adherence is above 80% versus less than 80%, there's quite a bit of a difference in that efficacy. So 86% versus 45%. And the grade of evidence is high for those. For heterosexual populations, similar story. So highly effective if it's taken over 80% of the time, but it's really not effective in terms of what the trials have shown us when people do not take it as frequently. So just a note about injectable cabotegravir. I won't really focus too much in this talk on that because that, again, in itself could be its own hour-long talk, but it has been shown to be superior to oral FTDF in 2 trials, HPTN 083 that evaluated this in cisgender men and transgender women. You can see the hazard ratio there, over a 60% reduction in HIV new diagnoses. And then HPTN 084, same idea, but this was in cisgender women, and an even more significant reduction in new HIV diagnoses compared to FTC TDF. So even with that, we now have multiple agents that people can be on for PrEP, but we know that the need is still high. So the CDC estimated that in 2021, about 1.2 million people or more had a need for PrEP. However, only 25% of people who had a need for PrEP were actually receiving PrEP. So we've got a really big gap here in terms of the PrEP versus need ratio. And it's underutilized throughout the United States. So this is an image from AIDSview.org. If you've never gone to their website, I encourage you to do so. They've got a lot of punchy graphics and really interesting information broken down by many categories. And so here we're looking at the number of PrEP users in each region of the United States compared to the number of new HIV diagnoses there. So the South, there are 11 PrEP users for every new HIV diagnosis compared to the Northeast, where PrEP coverage is higher. There are 22 PrEP users for every new HIV diagnosis. And there are, of course, disparities in PrEP access and use. So this is broken down by race and ethnicity. So in the United States, Black and Hispanic or Latinx people are disproportionately impacted by HIV, yet the number of PrEP users in those groups is low compared to white people in the United States. So 36 PrEP users for each new HIV diagnosis compared to only 4 for Black individuals and 9 for Hispanic and Latinx people. So a pretty stark difference there. And when we look at the inequities over time, although the rate of PrEP use by race and ethnicity has increased for all groups from 2012 to 2022, really the difference between the groups has become marked. So you can see in the orange line on this right side of the graph shows the PrEP to need ratio, which is the number of PrEP users again in 2022 compared to the number of people newly diagnosed with HIV in 2020. So a sort of marker again of how much PrEP coverage there is compared to need. Higher ratios indicate that there's greater coverage. And so the white individuals there, it's very high, but the ratios have been stably low, under 10 for Black and Hispanic or Latinx persons over time, which signifies worsening inequities. And nearly all PrEP users in the United States are men. And so you can see here, 8% of PrEP users in the United States are women. So that's 6 PrEP users for every new diagnoses in women compared to 16 for men. And then when we look at subgroups of people, so key populations, including people who inject drugs, men who have sex with men, transgender individuals, racial and ethnic disparities are really the highest among transgender people. And we can see the transgender women on the left side and transgender men on the right. If you look at new diagnoses among Black or African-American people, it's a much higher proportion than the white individuals, and it's higher even than Hispanic and Latinx people, although I think both of those are still concerning. So we've got a lot of work to do, and I think the options that we have for PrEP are exciting, but we need to work on sort of how to get those to the people that most need them. So now I think we will move to our anchoring case study. And so I decided to do this kind of a little bit different, where I'll present a case and then we will sort of think through some of the options as I would as a provider. And then hopefully some of this is kind of relevant to everyone as we move through. So this is a 32-year-old biracial non-binary person, assigned male sex at birth. They use they them pronouns. They're coming to clinic to start PrEP, telling you that they've engaged in receptive and insertive anal sex with 3 male partners this month. And so my question for you, there's no poll, but you can kind of think of this for yourself. What PrEP medications, excuse me, are indicated for this person? So this is a very busy slide and is mostly meant to show you how many options there are and how it depends on the population in terms of gender and sex assigned at birth, and then also the behaviors that would give someone a particular risk for HIV. So we have to really think about those two things together when we're thinking through options for people. And so even more complicated than that, there are different bodies of organizations that have made guidelines. So CDC or Department of Health and Human Services in the United States, and then IAS, the International AIDS Society, USA, has their own guidance, and so does the WHO, the World Health Organization. And so we'll talk about how these kind of compare and contrast as we move through, but just to give you a flavor of some of the components that we consider when we're initiating PrEP on someone. So if we focus on this column here, which is a person who's non-binary, oral FTDF is an option according to the IAS USA guidelines for a person having receptive anal sex. FTIF would be an option as well. And then so would injectable cabotegravir. So how would we choose between these things? I think, again, we think about the person and what the behaviors are, but then also if there are any comorbidities or other medical issues that we should be aware of. So you've probably heard that for oral PrEP, there is a concern for potential renal issues after someone has been on the medication long-term. These are still rare overall, but something to mention. And so FTDF is contraindicated for people who have a certain creatinine clearance, which is a measure of renal function, so less than or equal to 60. And then for those taking FTAF or Descovy, we have a little bit more leeway there, and it might be a better choice for somebody who's in that middle range. And then if someone has significant renal function decline, so less than 30, we would consider cabotegravir for them when a tenofovir-containing product would not be recommended. And then there are also some concerns for bone issues. So if a person is at risk for osteoporosis or having brittle bones, you could consider getting a bone scan and consulting with the bone health specialist prior to using any tenofovir product, although TAF is more friendly than TDF. And if there are contraindications to CAB, which I think are few, you unfortunately can't prescribe PrEP at this time, but there are newer agents that are being studied and hopefully will become on the market in the next few years that will be an option for these individuals. So when should 211 or on-demand PrEP be considered? So for those who do not know, 211 or on-demand dosing or event-driven PrEP or disco dosing, all of these are the same terms to refer to a strategy where a person does not use PrEP daily, but they take PrEP around the time of a sexual exposure. So specifically in this graphic, you can see on the left, 2 pills 2 to 24 hours before sex, and then 1 pill after, and then another pill 24 hours after that. So you end up taking a total of 4 pills, and you have equal coverage as if you were taking it daily prior to the exposure. And this is a beneficial strategy for some people who are able to plan for sex and who maybe don't want to be on PrEP every single day. There are, again, some caveats for this. There are certain types of sex that we know that this covers, and there are populations that have been studied and ones that have not been studied. So this is a similar table to what I showed you before, now giving you the guidance from each of those 3 organizations. So for cisgender men, you can use this sort of regardless of sexual orientation, recommended for sexual exposures. We're not talking about injection drug use only for sex. And really, this is for people who can anticipate sex. For transgender women, IAS USA recommends that we use this with caution in those who are receiving hormone therapy. And actually, the WHO says that this is not recommended if someone is using exogenous estradiol products. And we will talk about why that is. For cisgender women, trans men, and then people who inject drugs who may not have sexual risk, there is insufficient data right now to support on-demand dosing. And so it's not recommended. We have to as well be aware that HBV or hepatitis B co-infection is important to diagnose because these medications, FTDF and FTAF, so tenofovir-containing products, have activity against hepatitis B and HIV. And so if a person has hepatitis B co-infection, HHS or CDC guidelines actually say this is contraindicated. WHO says it's okay to use, but I think the bottom line is you need to be aware that if you are taking PrEP intermittently, there is a risk of hepatitis B sort of flaring up because it's being intermittently treated. And so that's just a counseling point that will need to be reviewed with the patient if they have hepatitis B. So our patient opts for daily PrEP. So my question to you again, kind of thinking about the way you might answer, there's no poll here, but what should be explained about medication adherence for this person? So all part of the initial conversation that we have with someone who is thinking about starting PrEP. So again, many studies have been done looking at this. I'm just showing you sort of one here, the efficacy of PrEP in an open label study called IPrEX, where you can see they looked at the incidence of HIV depending on the estimated adherence that was measured by tenofovir levels and dried blood spots. So if a person's taking 7 tablets a week of PrEP, which is every single day, and that's obviously the goal, there were 0 new infections, so 100% protection. When we go down from that, so just 2 to 3 tablets a week, the incidence for HIV rises and the protection falls to 87%. And you can see as we go down to less than 2 tabs a week, we're really seeing, less than half or so protection, and the incidence is quite a bit higher. In general, I tell people, this is very, very effective if you take it. We have very few documented cases of people developing or acquiring HIV while having excellent adherence to PrEP. So there are less than 10 or so. There may be others that haven't been published, and a few examples there if you are interested to read about those cases. And this is just another way to sort of show this in graphic form. So this is looking at the HIV incidence for people in these different categories. So all the way on the right side, for those who take PrEP and are persistent on it, meaning they're continuing on it and having their routine monitoring as recommended, 0 new infections when we look over time. However, for people who are prescribed PrEP and then don't end up taking it, as we might expect, they're not using it, so it's not working, the HIV incidence is pretty high in those people if we follow them up over time. It's even higher in people who stop PrEP for whatever reason and then don't restart. And that's a specific group of people that we really want to focus on. And so what are some of the strategies that we can use to increase PrEP adherence? So I like to tell people they can work it into an existing routine. We want to try to manage expectations around side effects. So even before someone starts the medicine, telling them that they may experience some gastrointestinal side effects, so nausea, vomiting, in rare cases, diarrhea. with oral PrEP. And that should go away, within a week to 2 weeks after they start, if they stick with it. And then for injections with IM cabotegravir, there can be site reactions, so discomfort, some firmness, and those should go away within a couple of days. And so we can sort of counsel people about that. Again, having a preemptive discussion about the rare complications for bone and kidney issues, reinforcing that this is really an intervention that has high benefit relative to few and uncommon harms, and also telling people that, again, this has to be taken to be effective. We want to also normalize missed doses. Life happens, people miss a dose here and there. That's okay. You saw in that chart that we showed on a prior slide that there is a little bit of wiggle room, so to speak. So if a person takes 6 doses versus 7, the effectiveness is probably going to be about the same. But really, when we're dropping below 4 doses a week, someone's only taking 2 a week, that's when we run into problems. There are some strategies that may be helpful, and there's varying levels of evidence about the benefit for these, but check-ins or reminders, either through text message or email. Some people find using pill boxes to be helpful, and then peer-based navigation in some settings has also been helpful to improve adherence. There are still lots of barriers to people persisting on PrEP, and I think those are structural, individual, and social. And so for all of these groups you see in this first bullet point, young adults, various race ethnicity groups, women, trans people, those who are in rural areas, and those with substance use disorders, multiple studies have shown us that these are people who are more likely to discontinue PrEP. And so we need to focus our efforts to be even stronger to keep them into PrEP care and make sure that they stay on it when it's indicated. Around the country, there's also just an awareness sort of deficit and knowledge about PrEP, both for patients and providers, honestly. And some of this has to do with regional and cultural differences about how people prioritize sexual health, whether it's something that you should talk about or not, or whether it's kind of a taboo issue. Again, people are experiencing stigma related to PrEP use and don't necessarily want to disclose whatever behaviors might be an indication for PrEP. And along that line, there are also mismatches in how people perceive their risk for HIV. And that can be, on the patient side, but also provider side. And so all of this sort of wraps into being an issue where people have a lack of access to appropriate, unbiased, anti-racist, and trauma-informed care. So a lot of systemic issues that I think are important to think about. And as we are developing and maintaining our PrEP programs, we should try to tackle and dismantle these as much as we can. And the reason this is important, why people should persist on PrEP, is because the risk for HIV is high after people stop PrEP. So on the left side, you see several studies put onto one graph that show the HIV incidence after someone discontinues PrEP. You can see in Australia, it was pretty low, but in Canada, one study showed that incidence was 4% after a person stopped PrEP. So that's very, very high. And then in King County, we also looked at this in terms of men who have sex with men who had new HIV diagnoses from 2013 to 21, and showed that over 20% of those men with a new diagnosis had previously used and discontinued PrEP. So this is a major issue that I think, again, I don't have all the answers for, but there are some strategies we can sort of proactively establish to try to keep people on PrEP when they need it. So the next question is, what do you tell people about time to protection, and how to counsel about condom use, which again is maybe not the most interesting subject to some people. And would this be different if their risk of HIV infection was primarily through a method that was not receptive anal intercourse? So there are varying thoughts about time to protection and condoms with PrEP. So for oral daily PrEP initiation, we typically tell people, just based on the guidelines and kind of the evidence that we have, that condoms are recommended for 7 to 20 days after they start PrEP. Part of this has to do with how we think there's time to protection by anatomic compartment for different PrEP modalities. So for the cervical vaginal compartment, we think it's about 20 days. For peripheral blood, about 7 days, same for the rectal compartment. And we don't really have good estimates for the urethra, but we kind of assume that it's similar to those 7 days, or if it may be longer, it's not as long as 20 days, we think. We do know that some people will never use condoms. And so for them, there may be a benefit in them starting with a double dose of PrEP when they initiate to shorten the time to protection. And that is also endorsed by the IAS USA 2022 guidelines. And for injectable PrEP and FTAF, we really don't have enough data yet to be sure about the time to protection, but we estimate that it is probably about 7 days. So what are some practical considerations for when we are initiating PrEP? We really want to make sure that people are getting the correct HIV test for screening. So a test that has a short window period. So usually that's an antigen antibody test, and make sure that's negative within a week of starting PrEP. We do know that just being exposed to antiretroviral medications that are in PrEP, that can lead to delayed seroconversion and false negative testing. And so we want to make sure we have a high quality test with a short window, so not an oral fluid test if possible. And then false positive tests will occur. And so that's something to be aware of, not necessarily what we would advertise to a patient, but for those who are in PrEP programs, I'm sure you've had at least one false positive before, because we're frequently testing people in a low HIV incidence population. Point of care tests such as the INSTI are okay to do at the time of PrEP initiation if blood is also drawn for antigen antibody testing at the same time. And then, of course, every time that we're talking to someone who is coming in for PrEP, whether that's an initiation or a follow-up visit, we want to screen for signs and symptoms of acute HIV. So asking about fever, fatigue, rash, any exposures that they may have had that were not covered by PrEP. And again, you can jumpstart the time to protection with taking a double dose at initiation. I think that's reasonable to do. And I do talk to my patients about doing that, especially for people who have frequent exposures and don't feel like they can wait, the 7 to 20 days or do not want to use condoms. However, this is really a strategy that we try to focus on people who are using daily PrEP and for MSM and transgender women. So our patient comes in for their 3-month visit, getting refills and labs. And so the next question I want to tackle is whether or not the HIV viral load for monitoring is necessary. So CDC guidelines would say yes. The most recent iteration in 2021 shows this algorithm here where they are saying you should send antigen antibody and also an RNA assay for every person. And I think this is based on data from the HPTN 083 study that showed that there is some concern about missing incident HIV infections if a person's on PrEP with either FTDF or cabotegravir. And so in this study, we see that there were 3 baseline infections that were missed, but if a viral load had been checked at that time, they would have been detected. And then as you look over time, there were 6 additional infections that were missed by just antigen antibody testing that would have been caught by a viral load. And in 4 participants who had incident HIV infection at the time that they initiated, they continued to receive oral PrEP, and that resulted in 5 mutations that were M184V and then 1 K65R. So those are typical mutations for NRTIs that we see for people who are taking PrEP, who have acute HIV, or in people living with HIV if they're not taking their medication regularly. And another interesting abstract that was presented a few years ago now at CROI showed some discordant test results among Thai men who have sex with men who started PrEP during acute HIV. You can see in the highlighted boxes there at week 0 and week 24, the number of tests that were positive with the 4th generation assay or the antigen antibody, none of them in week 0, and then only 1 in week 24. And then when you look at the way that the diagnosis was made, most of these were by a viral load or a NAT, but some of them were with antibody, but it wasn't a later generation antibody, it was a 2nd or 3rd generation test. So again, this is just to kind of highlight that being on PrEP at the time that someone acquires HIV, if we're not screening for that, can make it a little bit difficult to diagnose. And I think that's the basis for why viral load testing has been recommended. But I think as a person who is interested in implementation science and sort of practicality from a public health perspective, I think the real thing that we have to think through is cost. And so if we do kind of a back of the envelope cost effectiveness calculation, just with the participants who were in HPTN 083, If we say that, that viral load is about $164 and someone's getting it 5 times, so at initiation and then follow up over the course of a year, you can see how much money that is, almost $2 million. And if we're just going to prevent new infections with resistance in 5 people, that shakes out to be about $375,000 per case identified. And so the question really becomes, is this a cost-effective way to monitor people on PrEP? So in practice, I have found that this is uncommonly ordered just routinely for PrEP monitoring for people on oral PrEP. I'm interested to hear what other people think. Some payers, insurance companies are actually refusing to cover PrEP viral loads for people. And so that's another consideration. I think cabotegravir is a different story. We definitely know that that can be problematic to diagnose people with a new infection. And so we want to get a viral load at every visit. But for oral PrEP, I think guidelines are sort of mixed. Some say to get it at initiation every 3 months, and then some say that you just want to screen for HIV with the signs and symptoms, and then only get an RNA if a person had a high-risk exposure in the last week. And then some say optional. So I think it's an open question. Okay, so this person comes back now and is saying that they're thinking about starting feminizing hormone therapy. So are there interactions between PrEP and hormone therapy? Another kind of hot topic in the field. So I'm going to present data from a few studies on this. So one study looking at levels of PrEP in transgender women who were on oral or injectable estrogen with also androgen blockers, and comparing those levels to cisgender men, and found that the trough levels for the components of PrEP were lower in transgender women, and that was statistically significant, as well as the area under the curve was lower, and they saw that transgender women had higher clearance of the PrEP metabolites. There was no difference when they looked at cells in the peripheral blood, and then they also did sigmoidoscopy to look at colon tissue. So when they biopsied those specimens, they didn't see any levels there, nor were there any changes in the estradiol levels before or after people were dosed on PrEP. So this study didn't necessarily show a difference in those rectal tissue concentrations, but an earlier study in North Carolina did see a 7-fold decrease in tissue concentrations for tenofovir among transgender women compared to other populations. And so the authors concluded that we should use caution, maybe with 2-on-1 dosing specifically for transgender women on hormones. Another study here looking at PrEP metabolite levels for people on gender affirming hormone therapy. So this was 24 transgender women and transgender men who received directly observed therapy and then had dried blood spots for tenofovir levels. And again, showed that the active metabolite was 23% lower among transgender men compared to cis women. Otherwise, there was no difference between the groups. You can see these sort of plots here. They all seem to be clustering sort of around the same level. They also found that serum hormone concentrations were not affected by FTDF use. And when they looked at projected levels of PrEP coverage in terms of the active metabolite at 8 weeks, which is what they kind of estimate as the steady state, they found that the levels were equivalent to people taking 4+ days of PrEP per week. So pretty good levels. And then one last study to show here, this was presented at CROI in 2022. No change in active tenofovir levels by dried blood spot at 12 weeks in different transgender populations who were or were not on hormone therapy. And I think what was also interesting in the study is they looked at the way that people perceive their body while they were on gender therapy. So satisfaction was the same between people who were or who were not on PrEP in the two groups. And people didn't have any sort of subjective change in terms of their body image. So also sort of an important metric to consider, not just the biologic kind of levels of drug, but also the way people perceive themselves. Okay, now the patient kind of tells you they started a new relationship and they want to give PrEP a break. How long should they continue on PrEP after their last condomless sexual exposure? So this is just a general schema here to kind of show for these different strategies. PEP, someone has an exposure, they take medication for a period of time after that. For daily PrEP, you take it every day because you're having frequent regular exposures. And then for intermittent PrEP, you're only taking it around the time of planned occasional exposures. But when we think about how to safely stop PrEP, it's a little bit nuanced. So for oral PrEP, WHO says a person should take 1 dose per day for 2 days after their last exposure. If they're a person assigned male sex at birth, they should take 1 dose a day for 7 days. If they're a person assigned female sex at birth, again, going back to some of the thoughts that we have about how PrEP protects people at different anatomic sites. CDC says it's important to document the HIV status at the time of discontinuation, and that protection will start to go down within 7 to 10 days after the last dose. And we want to counsel people about, again, that risk for HBV flare if they are known to have co-infection. For injectable PrEP, it's a little more complex. So the levels of the medication really last for a long time in someone's body. And so if someone is going to be on injectable PrEP and then they decide to stop, the recommendation is to transition to oral PrEP for the period of ongoing risk. And the reason for that is pictured here in this graph. For both men and women, the levels of cabotegravir stay active in the body for up to a year and even longer after the last dose. And so the concern is if the level starts to drop below the point that we think it has adequate coverage or protection against HIV, that resistance could develop. And so a person is recommended to be on oral PrEP for the period of time that they continue to have risk after they stop cabotegravir. But again, that's a whole other sort of issue where it's complicated to tell someone who opted to be on injectable PrEP in the first place that now they need to take oral medication. It's a little bit of a confusing situation for people, but more to come on that as we learn over time. So this person elects to try 2-1-1 dosing, and outreach attempts for our clinic are unsuccessful for the next 6 months, but then a refill request comes in. So the question now is, how can our system really engage PrEP patients to continue to sort of let us know how they're doing and really allow us to help them stay on PrEP? Well, there are a lot of, again, structural interventions for increased PrEP engagement and adherence. So I find that the importance really is for bidirectional communication. So that's whether through email or MyChart, if you have an electronic health record, asking people to tell us, like, if you decide you want to stop PrEP, if something's going on, you can't fill your medication, if you're having side effects, please let us know. And we will also be transparent and communicate with you. There are a lot of other methods that people have evaluated. So telehealth, low barrier clinic models, mail order models, and peer-based adherence support that could be helpful. And then for trans and non-binary people, also thinking about incorporating PrEP care into your gender affirming care or their primary care services. And then people who use substances or alcohol, incorporating PrEP into delivery services at syringe exchange programs, other harm reduction services. Contingency management has also been evaluated. Just generally kind of rolling this into behavioral health can be helpful. Okay, so the person then comes to care several months later after having run out of PrEP a couple of months ago and now say that they had condomless sex with a person who was diagnosed with HIV but is not taking medication last night. So now we want to think about prescribing PEP for this person or post-exposure prophylaxis, but the person tells you, I'm worried about taking more than 1 pill a day. So what are our options here? So CDC, HHS guidelines talk about PEP and the different regimens that we have available. This is based on the 2016 guidance. So dolutegravir plus FTDF is an option, and then also raltegravir plus FTDF. And there are alternatives, so boosted darunavir with FTDF, and then also for people who have a lower creatinine clearance, there are, again, other alternatives that are not as easily tolerated. The key, though, is this has to be taken within 24 to 72 hours of PrEP exposure. But we know that there are still multiple barriers. So this person cited one of them, which is, they don't want to take so many pills per day and they're worried about side effects. But generally speaking, I think providers are uncomfortable around the country. So maybe not necessarily here at the University of Washington, but across the country and in other parts of the world. There's still a lot of stigma associated with this, both on the provider side and people seeking PEP services. There's disparities in terms of geography, in terms of who knows about PEP and how to use it. And all of that sort of factors into the unfortunate fact that there is limited access to providers, and then also if people are trying to investigate how to get PEP, they have a really finite period of time that it will be effective in, so 72 hours. Adherence can be challenging for side effects. We'll talk about that in a second. But there are, thankfully, multiple examples of successful programs for same-day PEP, early initiations, and then also transitioning people to PrEP thereafter. And overall, I think PEP use may be actually declining, and part of that may be because we're doing a good job in getting people onto PrEP so that they don't need PEP. But to this person's concern about taking more than one pill a day, there have now been several studies looking at using Biktarvy or Bic-F-TAF as a 1 pill a day option as PEP. So it seems to be safe, well tolerated, and then comparable compared to other regimens. So in these studies, they found adherence was high, over 95%, and that few people discontinued due to side effects. Mostly those were fatigue, headache, diarrhea, nausea. So the same as they would be for even for PrEP regimens, honestly, but seem to occur less frequently with this co-formulated option compared to the recommended regimens that I showed you previously. And what I found was interesting at this past CROI was one of the researchers from Toronto presented a poster that showed this idea about PEP in pocket. So for persons who have low frequency exposures to HIV, they actually counsel people about having the option of PEP in pocket using Biktarvy or Bic-F-TAF, or the standard regimen of FTDF and dolutegravir. And they give a person a full 28-day prescription prior to an exposure, and they counsel them on how to use it and tell them that if they do initiate, that they should follow up with a provider in their clinic within a week to have HIV and STI testing. And so this strategy, you can see they employed in 69 total courses of PEP in pocket. Follow-up seemed to be pretty high at 6 months, so almost 100%, and they saw no HIV seroconversions, and it was tolerated well. And then they noted as well that they had several people who went sort of back and forth between the two strategies, so PEP in pocket versus PrEP, which I think was interesting. And then secondly, there was another abstract that CROI presented this past year about dynamic choice for HIV prevention. So this occurred in sub-Saharan Africa, where they gave people the option to either be on PrEP or PEP. And that was compared to standard of care, and they followed people for 48 weeks. In the people who had choice, 86% ever chose PrEP, 15% ever chose PEP. And notably, they found that this intervention, which was sort of a multi-component intervention, also improved the number of people who agreed to HIV self-test and also follow up outside of a clinic, so at a community site, whereas people previously had not been doing that, and sort of the follow-up was pretty poor. And so overall, this option that people had resulted in 2 times greater coverage for any biomedical intervention for HIV prevention compared to standard of care. So I'm not sure that we routinely do this here, but I think it's a really interesting consideration. So I will now sort of end talking a little bit about products in the pipeline. So this is our kind of current PrEP and PEP landscape. This is a graphic that Colleen Kelly presented at CROI this past February. And so looking again at oral PrEP, what options we have versus injectable, and the dapivirine ring, which is endorsed by WHO, but not going to be available in the United States. But really, it doesn't end there. There are a lot more options that are in either preclinical or clinical trials right now. So those range from diaphragms to enemas to implants, different subcutaneous injections, vaginal gels, and some of these can be co-formulated in sort of a multi-purpose fashion with things like contraceptives for people who want to prevent pregnancy. So a lot on the horizon, and it's really exciting to kind of think about all the options that we will have in the future. So stay tuned as we learn more about those. I just wanted to show a couple of interesting new modalities that were presented at CROI this past year. Some of these you may have seen from our CROI summary talk that we did earlier in the year. One of these is an ultra-long implant that can be placed into the body that has cabotegravir in it. So it's a biodegradable polymer that is mixed with the drug of choice, and so in this case, cabotegravir. And you can see here when they put it into the rat, you can follow it over time and see that the implant stays there until it's removed. and it provides appreciable levels of cabotegravir that seem to be protective at a year or longer at target levels in both the murine models and also macaques. There are also on-demand inserts for both PEP and PrEP. So these contain TAF or elvitegravir and then combinations of the two. So in a non-human primate model, there was great efficacy that was shown in either using one vaginal or two rectal inserts. And so they moved those to human trials and showed that it was well tolerated. There was a little bit of anal redness that occurred in one participant, and levels seemed to be high and were sustained for up to 48 to 72 hours. And they seem to exceed the levels that would be comparable to someone taking 4 to 7 tablets of oral PrEP per week. So exciting there as another option that people could take, a non-oral option. And when they use those same inserts for PEP, again, in a non-human primate model, they put the inserts in and then they expose the person to HIV, so a virus that's kind of similar to HIV, but for primates. And they showed again that protection was high. So at 4 hours, 100% protection, and then at 24 hours, 77%. So not perfect, but still pretty good. Lenacapavir is a new agent that is ongoing, sort of being studied as a HIV prevention method. It's currently already FDA approved for HIV treatment for those who are treatment experienced, but has been shown in macaques to have been challenged with HIV or HIV to have pretty good protection. So 63% in the untreated versus 27% in the treated when target levels were reached. So there are currently PURPOSE 1 and 2 trials and soon 3 and 4, which are phase 3 studies that are going to be looking at this long-acting agent for PrEP. So stay tuned for that. It seems like this will be probably subcutaneous dosing that will be done every 6 months. And then lastly, implants that can be put into the body and then refilled. So using islatravir, this is another option that I think could be exciting for people who don't necessarily want to take pills or put in, inserts into the rectum or the vagina. They could have this sort of implanted into the arm, and it's the size of about a penny, and then just needs to be refilled with the appropriate medication once it runs down. Okay, so conclusions here. I think we've talked about a lot of these things, but PrEP uptake remains suboptimal in the United States, especially among populations with high HIV incidence. Prevention options we have for nearly every person, and so that should never be a barrier. We have either daily or 211 oral options versus injectable, and there are many others that are coming soon, we hope. Adherence can be improved if we take a proactive and anticipatory counseling approach. PrEP persistence still remains a challenge, and we know that PrEP discontinuations are common and associated with future HIV acquisition risk. And so we want to do everything we can to keep people on PrEP who need to be. PEP in pocket may be an emerging strategy in our prevention toolkit. And again, there are many exciting new options in the pipeline. So as we close here, I wanted to just plug a new curriculum. So it's going to be part of the IDEA group, and you all, I think, know the National HIV curriculum and our Hepatitis B and C online that David Spock has spearheaded. There will be a National HIV PrEP curriculum that will be coming soon. So hopefully within the next 1 to 2 months that will be live, and we'll have all of this information there, great graphics, a lot of teaching for learners, ways that you can sort of on the fly look up any information, and it will also, we hope, be a good resource for people who are sort of on the ground and dealing with PrEP patients and clients. So just a few more resources here, including the UCSF National Clinical Consultation Center for PEP. If anyone ever has a question about PEP, that is a great resource. You can call them in those hours there and sort of have a warm consultation. And I've used it myself and found it really helpful. So that is it. Hopefully we have a few minutes for questions.
Yeah, we have quite a bit of questions.
Okay.
So to get the first one started. Okay, the number of people needing PrEP, who is considered in need, and that number, given we are to be offering it to anyone who wants it?
Yeah, it's a great question. So the way that they kind of look at this, I think, is based on sort of indications for PrEP for people who either have had a previous STI. So, if somebody comes in and they had early syphilis or rectal gonorrhea, that is an indication to us that that is somebody who likely could benefit from PrEP. So there's a lot of different ways that they can kind of do this. I have asked the group that runs these analyses sort of what sort of factors go into this, and I think it's pretty complicated. If you're interested in that, I think you could reach out directly to their group. They're happy to kind of share more with you, but generally it goes based on people who have a PrEP indication based on CDC guidelines. But I recognize now that is different, as it could be open to anyone essentially who asks for it.
Okay, next one, and I believe this was back in slide 28, the 211 slide, or maybe 27. I think that's what they're referring to, slide 27.
Yeah.
Just to clarify the previous slide, if someone has a contradiction to CAB, then they shouldn't be prescribed PrEP at all, or just that form of PrEP.
Yeah. So that was meant to say, typically we start with oral PrEP for people and discussing options. And if they, are not interested in oral PrEP and they want to do injectable, then we have to, sort of make sure that they qualify for that, they can get it covered. Insurance really is a barrier, and that's one of the reasons that we don't use it in our clinic. And I have not had very many people that I know start on it, although it's certainly possible. That slide was meant to show that if a person can't take cabotegravir for whatever reason, they're on a medication that interacts, or they have an allergic reaction to the medication, then there isn't another option at this time for PrEP if they can't use oral medication. So it's really those three options, the two oral PrEP options or injectable. And if they can't tolerate any of those, or they're contraindicated because of kidney issues, then there is nothing else for them at this time.
Okay. Next question. Do people taking PrEP before the age of 30 be thoroughly counseled about bone density? Because below 30 or under 30 is when most bone development occurs.
Yeah, potentially. I mean, I think I'm not as concerned about this as sort of as a provider when we're talking about someone who is going to be initiating on PrEP, who may be taking this either sort of daily just for a season. So, people maybe take it when they're not in a relationship. So that may be, a year, and then they kind of stop. I think that's different in terms of the total exposure that someone has to these medications versus someone who would be taking it every single day for like HIV treatment. Even so, I think that this is still a rare outcome. Millions of people have taken these medications across the world, and I think we don't see this happen very often, but it is something that there has been some predatory action. I've had patients come in who say, I was contacted on Facebook by this law firm who said, have you ever taken PrEP before? You can sue, get in this class action lawsuit because your bones could be damaged. It's not really frequent at all, but I think we tell people about it because it's on the sort of list of potential causes, but it is still pretty rare. And I do try to emphasize that. So I don't think we need to be generally worried about bone health for young people. Because honestly, again, the benefits of being on PrEP in terms of HIV prevention far outweigh any of the risks.
Next question, would the 211 initiation of daily PrEP also be effective protection for people with vaginas?
Yeah, that's a great question. We don't know because it hasn't been studied as far as I know. And if others know different, please do tell us. But biologically, I think it could work, but I just am hesitant to offer that to people with vaginas just because we don't have great evidence on it. But I think theoretically speaking, I don't understand why there wouldn't be higher levels if you did a double dose. But I just wouldn't feel confident in saying that you have 100% protection at the vagina if you had an HIV exposure within 24 hours of taking a double dose. So I would be cautious about that.
And next one, what do you think about the recommendations to get a viral load instead of just the ABAG test?
Yeah, I've heard that people are doing that in the community, and I guess that could be a strategy. I do think that there is sort of benefit to still sticking to the guidance and sort of getting the antigen antibody, because I think overall that's more accessible. It's going to be cheaper and likelihood that it will be covered is higher. But I think it's possible that you could just use a viral load, but I don't think that that's really commonly employed for the reasons we kind of talked about, that people are already kind of running into issues with it being covered. Yeah, it could be done. I guess it's not a strategy that I have heard of being widely used.
Okay, let's do one more question of PrEP, and then there's a few for PEP.
Okay.
Okay, in regards to the double dose at initiation, would this be 2 tabs of Truvada daily for a full 7 or 20 days?
If we're talking about men who have sex with men or a transgender woman, if they're saying FTDF or Truvada that they're starting for PrEP, they would take 2 tablets that first day, and then they would continue thereafter with daily PrEP. So instead of them having to wait a full, 7 days to have adequate protection at the rectal site, they should have it within that sort of after that 24-hour period that they've taken the double dose. So it sort of shortens the time to protection from the 7 days to 1 to 2 days. And so for people who prefer not to use condoms or who have very frequent sex, I think that is typically something I recommend to kind of get them protected faster when they initiate on PrEP.
Okay, let's do some PEP questions. How long can someone hang on to a PEP regimen before the medications expire?
Yeah, that's a great question. If there's a pharmacist on the line, maybe they can answer that. I mean, I think generally all of the bottles will have a sort of use by date, after which medications expire. I will not necessarily officially say whether that should be the date you exactly stick to. I don't think the medications just disintegrate into thin air once it hits that sort of arbitrary date. But generally speaking, medications are good for several months after you give them a new bottle. And so if somebody doesn't use it for 9 months and it expires, I think then you would sort of look to get them a new prescription. But it does bring up the issue about potentially wasted medication and cost. So this is a fully suppressive regimen that someone, say for instance, living with HIV could be taking. So there's sort of ethical, kind of financial and implementation considerations there that are interesting to think about.
Okay. Have you been able to get PEP in pocket covered? How do you code this?
I have not. So I just presented this because I felt like it was an interesting concept that they're doing in Canada. And when the researcher who was presenting this poster happened to be just standing next to me at Croy, next to mine. And so I chatted with her a bit, and they're able to get this covered because they have a fund that they can sort of basically get the medications for people. And I think their system is very different, obviously, the Canadian health system than the US system. And so I have not heard of this being done in the United States. If others know about this, please do share. But I agree, it's challenging to get it covered even when someone needs it like just one time. So doing it before there's an actual exposure, I think is going to be hard to implement here in the US, just based on how our health system is and how expensive these medications are.
Okay, one more question. Is the 1 pill a day PEP option widely available and comparable in cost to the 2 pill regimen?
So comparable in cost, it's still more expensive because the co-formulated BIC-F TAF option is more expensive than the option that has FTDF in it and dolutegravir, because the FTDF component is now generic. So it is a little bit cheaper to do that, but I think still these options are wildly expensive if someone had to pay out of pocket for it. So generally we're thinking about, somebody has to have insurance or some kind of coverage for this, because otherwise it's not accessible to everybody. But if you have the availability to get BIC-TAF FTC or Biktarvy, it could be a good substitute. There's no reason to think it wouldn't work in terms of efficacy.
Okay, all right. Well, thank you very much, Dr. Cannon. We are at time, so thank you everybody for joining us this morning. Just a reminder, we do not have an AIDS clinical conference in August, so we'll take an August break. I hope everybody enjoys their summer. We'll be back on Tuesday, September 19th for our next September 19th. Next ACC, it's going to be an IAS update. So thank you very much, everybody. Hope everybody has a great day and a great summer.